Ready? Hello, everyone. Ooh, I can hear myself. Hi, thank you for being here today. My name is Olivia, and I'm the president of HELPS, which has put on this great event tonight. From all of us at HELPS and Willamette University College of Law, we'd like to welcome you here today for a great presentation. At this time, I'd like to pass it off to our esteemed moderator and professor, Professor Howell.
Thank you and good evening, everyone. It's my great honor to be able to introduce Governor Kitzhaber to you tonight. He is the longest-serving governor of our state. He was elected to the Oregon House of Representatives in 1978 and the State Senate in 1980, 84, and 88. He continued to practice emergency medicine, and so that gives him a really hands-on approach to what he's going to talk about this evening. I mean, he's been in the trenches, and I like that. During his third term as governor, he was the chief architect of Oregon's coordinated care organizations, the first effort in this country to form a statewide basis to meet the triple aim: better health, better quality, lower cost, with a focus on community and population health. Over the past 5 years, Oregon's new CCO care model has reduced the Medicaid cost trend by 2 percentage points per member per month, realizing new fund savings of $2.2 billion. Modern Healthcare magazine in 2013 ranked him as 100 most influential people in healthcare in our country. While he also practices and looks after healthcare and studies, he's also focused on our environment. And he has championed many causes to bring together our very disparate healthcare system. I will turn it over to Governor Kitzhaber, but I think I know him a little bit. I've been here 8 years and in Oregon and live downtown, and every now and then, about once a month, I'd be out walking my dogs, and Governor Kitzhaber would be having coffee behind the museum. And he got to know my Basset Hound and my French Bulldog, and I think he liked the Basset Hound best. But anyway, may I present to you Governor John Kitzhaber. Thank you so much.
Thank you very much. You know, it's really nice to be down here. I was surprised to be invited and absolutely delighted to be here. I know that not everyone in the audience is affiliated with the Willamette Law School, but I do want to target my remarks particularly to those students who are seeking a career in the law. Because the law, at least in its purest form, is about seeking justice in an increasingly combative and polarized society. And seeking justice in the political world involves trying to balance the needs of individuals with the larger needs of society. So what I want to try to do tonight is I want to leave you with two things. I want to leave you with a better understanding of the U.S. healthcare system and its challenges and what we can do about it. And I also want to leave you with an understanding of how our healthcare system is actually undermining social justice and is a major factor in driving the growing inequities and disparities that we have in our country. I'm going to do kind of a high-level presentation, and we'll have lots of time to bore down on anything you want to talk about and just have a general conversation. So let me start with a story. When I was an intern in 1973, I watched a baby die. We called him Sam. He didn't really have much of a chance from the start. He was delivered in the emergency room to a very young woman who showed up late at night in labor. She was anemic, malnourished, and little Sam wasn't breathing when he was born. And we had to resuscitate him before we transferred into my service, which at the time was the neonatal intensive care service. So I was part of his life from the moment he was born until he died 2 days later. And I can remember standing by the bed, the incubator, during his last hour, knowing what was going to happen and feeling depressed and helpless. And he was so tiny. He was less than 3 pounds. His skin was kind of pale pink, almost translucent like mother of pearl. And he had a mask over his nose and his mouth that carried warm mist and oxygen from this green tube. His little belly was really distended. When he tried to breathe, the tissue between his ribs was sucked in with the effort. And one of his little hands was holding onto that green plastic tube, just as trying to find something that was stable. And his little eyes held mine. And we looked at each other as if from a great distance, and as though the look was magnifying the level of his desperation and magnifying it out into the rest of the room. And I knew he was going to die. And I knew there was nothing I could do about it. And still his eyes held mine, or it felt like that. And his chest was heaving up and down, and then he just wore out. And the movements went less and less and less until they were just imperceptible. And then it felt as though his eyes flashed at me, like he was inviting me to come with him, giving me a chance to join him beyond the struggle. And then the light went out. And there was nothing but the sound of the mist, oxygen coming up and around the mask. So Sam died in the intensive care unit of a modern hospital. He didn't die because he lacked access to the healthcare system. And his mother was on Medicaid, and he didn't die because he wasn't covered. He died because he didn't get access to the most basic social investments that are essential for healthy pregnancies and stable families. He didn't die, in short, because he lacked access to the healthcare system. He died because we failed to make the basic investments that he needed to have an equal opportunity to live and an equal opportunity to survive. So one of the points, really the central point that I want to make to you tonight is healthcare is not synonymous with health. We've lost sight of that fact, which is a real problem. And it's also one of the main drivers that is increasing the inequities in our society. And unless we can change the focus of the debate from financing and delivering medical care to improving health, we're never going to get our arms around this. And it's also a system problem. So you can't solve it by tinkering around the edges and dealing with symptoms. You have to deal with the system itself. So let's take a few minutes and take a look at the system and why we can't seem to get our arms around what I think is one of the most pressing domestic challenges that we face. So there are 2 basic reasons, I think, for why this debate is gridlocked. The first one is that we're asking the wrong questions. Neither Republicans or Democrats assume any fundamental change in the healthcare business model or cost structure. We either pay for it or we don't, which creates this zero-sum false choice between cost and access. So Republican efforts in 2017 to defund the Affordable Care Act were efforts to reduce the amount of money that we spent on a hyperinflationary, dysfunctional medical system. Democratic efforts to pass Medicare for all are ways to spend more money on the same dysfunctional, hyperinflationary medical system. The second reason is that we lack any clear consensus on what we're trying to achieve, on what our objective is. As the Roman senator Seneca once said, no wind is the right wind if you don't know what port you're sailing for, or if you don't know where you're going, any road's the right road. So let's start there. Let's have a conversation about what we're trying to accomplish when we want to reform the healthcare system. So I think it's fair to say that none of us want to be patients. None of us want to have to need the medical system. Now, when we do, we want timely access to quality, affordable medical care. But we'd much rather be healthy. So the point is that healthcare is a means to an end. It's not an end in itself. It has absolutely no intrinsic value outside its relationship to a positive health outcome or to alleviate suffering, except as an economic commodity, which is pretty much how it's viewed in our system today. Furthermore, we know that among the things that have the greatest impact on lifetime health status, medical care is a very minor contributor. Far more important are things like healthy pregnancies, housing, nutrition, stable families, safe communities, a good job, the social determinants of health. But at 18% of our GDP, healthcare more than anything else is undermining our ability to invest in the very things that have the greatest impact on health. So if we can assume, just for argument's sake, that our goal is health, not simply financing and delivering medical care, and if someone disagrees with that, that'll be a real interesting conversation we can have at the end as well. But let's assume, for argument's sake, that the purpose is health. If we agree that the purpose is health, then we can capture the policy objective in one sentence: to improve the health of the population through a financially sustainable system that, one, ensures all Americans have timely access to quality, affordable, effective medical care, and can make effective long-term investments in the social determinants of health. Now, to create a system that meets that policy objective, there are 5 key design elements. You have to have universal coverage for a defined benefit, with the delivery system at risk, at financial risk for producing quality and outcomes, in a global budget that's indexed to a sustainable growth rate, with the savings invested upstream in the social determinants of health. So the point is, a system that is designed with those 5 elements can take a dozen different forms. But without all 5 elements, you can't achieve that policy objective that we just discussed. Now, the greatest obstacle to achieving this policy objective is the total cost of care and cost shifting. Now, if you think about it, healthcare is the only economic sector that produces goods and services that none of its customers can afford. Nothing else works like that. So the only way this system works is because the care for individuals is heavily subsidized, increasingly with public resources, either directly through Medicare and Medicaid and CHIP, or indirectly through the tax subsidy for employer-sponsored coverage, or the subsidies that people get if they get their care through the ACA exchanges, right? So I have a little something here I call it the subsidy map, and it shows that 92% of Americans depend on public dollars to finance their health care. So if you're on Medicaid, your subsidy comes from the state and federal government. If you're in the ACA exchange, your subsidies come from the federal government. If you have workplace-based coverage, the subsidy comes from the federal and state government and your employer. And if you're on Medicare, it's a federally subsidized program. 92% of Americans. The only people who aren't getting a subsidy are the 27 million uninsured, who, while not entitled to a public subsidy, through their taxes, are subsidizing health care for everybody else. And these people are working because they're making too much to be on Medicaid. And that is one of the most egregious inequities in the healthcare debate. And it's one of the things that's driving the overall system. The point I want to make is our system only works because it's propped up with public dollars. So I would argue that what's at stake, the central point of contention in the healthcare debate, is public resources, the allocation of public resources, who gets them and who benefits from them. And public resources have 2 distinct characteristics. First, they are part of what I call a fiscal commons. They're raised from everybody, and they should be spent in a way that benefits everybody, not just some of us, which is clearly not what our U.S. healthcare system does. And secondly, they are finite. They're limited, which means that public dollars spent on one thing are not available to spend on something else. So the more public dollars we spend on healthcare, the less we have available to spend on education, for example, right? So Thomas Pynchon, in his book Gravity's Rainbow, wrote that if they can get you asking the wrong questions, they don't have to worry about the answers. For years, we've been asking the wrong questions. The healthcare debate has been focused on the subsidies, on how big they are, on who pays them, on who gets them, rather than on why healthcare costs so much in the first place. And if you watch the Democratic debates, that's a peripheral issue. It's all about how we pay more to give people access to a dysfunctional healthcare system, right? So why does the system cost so much? The system costs so much because the system is increasingly driven by maximizing revenue. First of all, the unit price for everything in the U.S. healthcare system is dramatically higher than any other country in the world. Secondly, and this is very disturbing, there's a dramatic increase in private equity investors that are buying up the most profitable parts of the system and then rolling those over for sometimes up to 400% ROI. And finally, you've got hundreds of healthcare startups that are focused on individual parts of the system trying to maximize revenue. Very few of them are taking a holistic view, and none of them are competing for the 27 million people who can't afford care, or for the growing number of people who are covered but have high copayments and deductibles. And that's a real problem. So what's happened is this profit-driven system has driven up the cost of health care to the point that neither private sector employers or the government can afford it. But instead of confronting the cost, trying to manage cost, trying to bend down cost, these two third-party payers use one of 5 well-tested means to shift the cost. So they either cut eligibility, cut benefits, or increase co-payments and deductibles, and those all shift costs to individuals. They cut provider reimbursement rates, sometimes to the point that hospitals and doctors will refuse to see or try to avoid seeing people who can't pay or who get reimbursed less than commercial rates. Or, and this borders on immorality, we just shove it into the national debt for our children and grandchildren to pay for. Right? So cost shifting is the way we avoid directly confronting both the reality of fiscal limits and the fact that health care now has exceeded the ability of individuals and government and employers to pay for it. And cost shifting does nothing to address the total cost of care. And this, my friends, is the fundamental structural problem with the U.S. healthcare system. There is no ceiling on the total cost of care. There is no constraint on spending because both employers and the government have off-ramps. They don't have to deal with controlling costs. They can just shove it onto the backs of individuals or private sector employers who then shove it onto the backs of individuals, or we put it into the national debt. The only way you can address this, and it's taken me 40 years to come to this conclusion, 40 years involved in the practice, politics, and policy of healthcare. The only way you can address this is you've got to cap the total cost of care through a global budget that's indexed to some kind of sustainable growth rate. Now, to understand that, let's look at 3 of our design elements: universal coverage, financially sustainable system, and investing in the social determinants of health. Universal coverage, because we know that unless everybody's covered, you continue the cost shift. A financially sustainable system that recognizes the limit of public resources. And investing in the social determinants of health, which recognizes the fact that health is the product of a number of things, only one of which is medical care. From a political and economic standpoint, the only way those 3 things can exist at the same time is if expansion in coverage is accompanied by a reduction in the total cost of care. So for the last 7 years, Oregon has been demonstrating exactly how you do that. And those of you who aren't familiar with our CCOs, I'm going to give you just the high points. So back in 2011, if you recall, Oregon was in the depths of the Great Recession like everybody else. We had one of the highest per capita budget deficits in the nation. We had a divided legislature. The House was 30-30, Republicans to Democrats, slim majority in the Senate. The state was polarized. We'd just gone through the fight over 66 and 67, the 2 tax measures. Most people would look at that and say, this is the formula for political disaster. It didn't happen. $1.2 billion of that deficit was in the Medicaid program. And it became clear that without replacement revenue, which we didn't have in 2011, we were either going to have to drop tens of thousands of Oregonians off the Oregon Health Plan or cut provider reimbursement rates around 40%. Those are both cost-shifting methods that we discussed earlier. And to the credit of the legislature, we said, no, we're not going to do that. We're going to take a third path. We're going to come together and try to look at the delivery system. So I front-end loaded the money we had in Medicaid into the first year of our 2-year budget, which brought that provider cut down to about 10%, which people were okay with. But that left a $600 million hole in the second year of the biennium. And our plan was we were going to close that hole by transforming the healthcare delivery system to get more value for each dollar spent. And we were going to do that through a new organization called the Coordinated Care Organization. Well, let's see. What's going on here? What's happening when I push this is my slides here going up but not on the screen. Huh. You can tell I don't understand this stuff. I'm glad I'm not into the dramatic part of my speech because this would have just taken the edge right off it.
Oh, wait. Ooh, what did you do? Janelle.
See, I can get this. Now, you're young enough, so you should be able to do this in your sleep, right?
I don't know. Resume. There we go. There we go. There you are. Do you want to try this?
Oh, got to go back. Whoa, congratulations. Thank you very much.
Let's go back around that way.
There we go. Okay, coordinated care organizations. So these were designed to be a different kind of an organization that was locally based with local providers, local citizens, and a local governance structure. And they were supposed to take a more holistic view of community health, not just a narrow clinical view, right? We have had 16 of them, we now have 15 of them. So in March of 2012, we passed the legislation that created the coordinated care organizations. And by the way, it was a vote in the split house of 53-7. So we demonstrated this does not have to be a bitter partisan issue. By then, however, it was really clear that even if we could realize cost savings, we weren't going to capture that money fast enough to be in the 2011-13 biennium. So on May 1st, I went to Washington, D.C., and we were able to convince the Obama administration to give us the waivers necessary to use this care model in the Medicaid program, and to give us a $1.9 billion one-time 5-year investment in the care model in exchange for a commitment to cut the medical inflation rate by 2 percentage points from 5.4% to 3.4% per member per year by the end of the second year of the waiver, without cutting benefits, without cutting enrollment, and meeting rigorous metrics around access, quality, and outcomes. So it's important to recognize that this $1.9 billion loan, which is really what it was, wasn't to allow us to just prop up the old Medicaid program during the revenue shortfall of the recession, but to actually give us a 5-year glide path with the $1.9 billion going down as the savings from the CCOs went up. And that's essentially exactly what happened. In the first waiver period, the state operated within the 3.4% growth cap. We expanded by 385,000 more people under the ACA expansion. So we dramatically expanded coverage. All the CCOs met the quality and outcome metrics, and we saved total fund savings of $1 billion over that 5 years. And if the legislature or the administration don't screw it up, that is supposed to reach $8.6 billion in savings over 10 years. So we have almost a million Oregonians, 25% of Oregonians and 60% of our kids are in this quality, affordable care model. That is an accomplishment unmatched in any other state. And it clearly demonstrates that you can expand access and reduce cost at the same time. Do we still need to advocate for universal coverage? Absolutely. But if we seek to do that only by putting more money into supporting the current dysfunctional healthcare business model, we will be abandoning millions of nameless, faceless people we don't know, whose health and whose opportunity for a better life will be compromised because of the cost of the system. And let me give you an example, one that I know very well, that touched me deeply. I've just changed the names of the people who were involved. This is a story about Susan and Patty. Susan was born into an abusive family, and she was sexually and physically abused by her alcoholic father until eventually she fled to the streets of Portland. And there, alone, homeless, desperate for love, desperate for a place to live, she was victimized, continued to be victimized. She began to use drugs and alcohol and eventually got pregnant. So alone, with no emotional support, with no prenatal care, she continued to use drugs and alcohol during her pregnancy. Now, the birth of a child, surely one of life's most beautiful, greatest gifts and joys, for Patty was a nightmare. For Susan was a nightmare. When her daughter was born, she was diagnosed not only with great prematurity, but with fetal alcohol syndrome. Susan returned to the streets, where she remains today, if she's still alive, homeless, transient, and addicted. At the age of 19, any chance she might have had for a normal, healthy life, a life of contribution, a life of satisfaction, is all but evaporated. Patty, who's now a ward of the state, was diagnosed with multiple behavioral health issues, including attention deficit disorder. Her first foster family had to give her up because they couldn't manage it. She had 26 foster care placements before she was admitted to a residential mental health facility where she lives today. I know of no yardstick that can measure the depth of this tragedy. The tragedy of a young woman, addicted, transient, who will never know her daughter. The tragedy of a young girl who will live out her lives inside the walls of an institution. And the tragedy of knowing that we could have prevented this, but failed to do so. This had nothing to do with access to our acute care medical system. Nor would a policy of universal coverage have made any material difference in the outcome and the tragedy involved. This situation was the result of the violence of institutions. Institutions that have become obsessed with the delivery of medical care as an economic commodity at the expense of the health of our people. Sadly, this is not an original observation. This observation was made over 50 years ago by Bobby Kennedy, whose untimely death in 1968 was the inspiration for my own career in public service. On April 5th, 1968, the day after Martin Luther King was assassinated, Robert Kennedy made one appearance before the City Club of Cleveland. You should read the speech. It was a short speech. It was about the violence, the stain of violence in America. And then he said, "There's another kind of violence, slower but just as deadly destructive as the shot or the bomb in the night. This is the violence of institutions, indifference, inaction, and decay. This is the violence that afflicts the poor, that poisons the relations between men because their skin has different colors. This is the slow destruction of a child by hunger and schools without books and homes without heat in the winter." Schools without books and homes without heat in the winter, and hunger and homelessness and families under economic stress, and the disintegration of neighborhoods, and unemployment, and the creeping menace of despair, and the fading hope of a better future. These are the cancers on the body of our community, and they have nothing to do with access to the U.S. healthcare system and everything to do with the cost of that system. And it is our failure to demand value for every single public dollar that we use to support that system that is directly responsible for our inability to make the kinds of investments that could actually bring relief to these struggling Americans, to these struggling Oregonians, and lift them up and give them health and give them hope of an equal opportunity for a better future. Our challenge is to move this debate beyond the false choice between cost and access by giving voice to the voiceless, by making visible those who are currently unseen. Now, notwithstanding the vitriol and acrimony that's flowing out of the building across State Street, we should not give up hope. You know, I was born here in the Pacific Northwest. I've had the honor of being a Western governor. I love this state, and I have a deep and abiding belief in the people of this state to make the right decisions for the right reasons if they are just given the opportunity. And certainly we're not immune from the hyperpartisanship and the loss of civility that's emanating from our nation's capital. But this state still has a deep, abiding desire and capacity for community. And although we certainly continue to have our disagreements, I believe that people in this state can still remember and can act on the fact that partisan is the choice, not a condition, and so is civility. So our challenge is to move this forward, each and every one of us. And I'll just close with the immortal words of Jean-Luc Picard. Let's make it so. Thank you. Thank you. Thank you very much. I had a picture of Oregon, but I can't find it. But you know what it looks like. So, I don't know who's in charge here, but I'm willing to take questions or...
Questions from the audience?
I know there's some student questions because I saw those in advance, so... Paperless questions. Want me to help you find them? Yeah. So the Oregon Health Plan, which is what we call our Medicaid program, I think had about 600,000 people in it. And again, if we had just done business as usual, we would have had to disenroll a whole host of those people. So we kept them covered. And then we went back I bought us time by front-end loading the resources. So I took the 2-year budget and I shoved most of it into the first year. So that's what kept them afloat. Then the next year, we got the waiver and the $1.9 billion. So what that did is it helped us keep them covered. And we knew the ACA was coming, and so we took that year before we got the waiver to identify all the people who had incomes that were going to make them eligible for the Oregon Health Plan. So we had identified them and connected them with the CCO. So we did a lot of work on the front end. And then when we got the waiver and the $1.9 billion, that gave us the cushion. And then over time, the cost of care went down the cost of care went down as we lost those federal funds. So it was the ability to have that $1.9 billion transition period.
So follow-up question. How would you see this applying on like national level? Because I thought it was really interesting your argument of like cost shifting, or like not cost shifting, but like reducing care. But like on a national level, we can't really take those funds to this above the period, right?
Well, if you could, they were federal funds. I mean, let's just step back for a second, and then we'll get to your question, sir. So I don't think this is going to happen on the national level. I just don't think it is. And if you look at the Democratic debates, they are not talking about the delivery system. They're talking about how to pay for something. And even if Bernie Sanders gets elected, and even if the Democrats take the Senate, we're not going to get enough to overcome a Mitch McConnell filibuster. So I think this starts at the state level. And so I think the next question in Oregon is how do we take this model and move it to the commercial market, right? Medicare already has something called Medicare Advantage, which is essentially a capitated model that requires, it's essentially a kind of global budget that has outcomes hooked onto it. So if we can get this fixed, by the way, I got some slides that'll go along with this conversation. So I think so that's the first question. How do you get it into the commercial market? Now, if you've been following things, there's a state task force on setting a total cost of care benchmark, which was set at 3.4%, which is kind of interesting. There's a certain symmetry with what we're doing with the CCOs. But the question is, how do you make that work? And in Oregon, it's going to require a more active involvement of private sector employers who are getting hurt by this. It's going to require a leadership role of public employees who constitute the largest self-insured part of our commercial market, and it's going to require some conversations between providers and insurers in Oregon. And one of the nice things in Oregon is that there are 5 insurers that cover 85% of the commercial market, and we know each other. So it's a place we can have that conversation. So I would argue that, let me see, right. Let me get down here. There's Don Quixote. There I am. So I'll just throw this out, and then I'll quit. So the way I see this happening is we've got to maintain the process in Oregon. We've got to maintain the CCOs. We've got to be able to extend this to commercial market. We've got to create incentives to move people on original Medicare into Medicare Advantage. Then I think what we do is we try to develop a 3-state collaborative along the West Coast. So all 3, Oregon, Washington, California, all 3 states have expanded under the ACA. They have fairly similar political philosophies in those 3 states. And if you were to do it, it's the 5th largest economy. If you just count Medicare and Medicaid, it's a $23 million purchasing pool that'll get the attention of drug companies, for example. And if we were able to get that alignment, you'd have the backing of 3 governors, 6 U.S. senators, and 68 members of Congress. So I'll just close that off by saying that we have something called the Pacific Coast Collaborative right now that was created in 2008, which is Oregon, Washington, California, and British Columbia. But it's basically a governmental entity that aligns the states around regional issues, primarily economic development and climate change. I would say we should explore creating something similar, the purpose of which is to develop a regional approach to healthcare. And if you could align the West Coast, you've got enough juice, I think, to begin to change the national conversation. Yes, sir.
I just want to say I really appreciate
Thank you.
I'm wondering how much are you making these presentations, and how much are you out there making presentations?
So I'm actually spending a lot of time on this. I'm obviously engaged in Oregon as to the extent that I can. I've through something called the Foundation for Medical Excellence. So I'm doing a lot of speaking here in the state. I've got a sort of an ad hoc group of providers, consumers, labor, business that are having sort of conversations about how we would take that next step with the commercial market. And then I've got a 501c4 in Washington, D.C., and I'm spending a lot of time back there basically trying to socialize this idea. We originally were hoping to get this into the presidential debates, and that's not going to happen. But I think that there's going to be a vacuum in 2021, regardless of who's elected on this issue. And I think it's very unlikely. Well, if anything happens, it'll happen in the first 4 to 6 months. And if they are unable to pull something off, there's going to be a vacuum. So what we're trying to do is provide an alternative conversation, a different way to frame the debate at the national level. So, yes, sir.
I'm just trying to understand what you mean by moving into the commercial market, because when I think about moving into the commercial market, there's always profit incentive, right? Which means that you're close to your discussion of a system that's driven by revenue growth. And so I'm struggling to understand how you move from the CC model to the commercial model.
So again, I believe that I think that the pathway to oh wow, okay, I'm going to give up. I'm making things worse here. I think that ultimately you've got to have the same kind of hard total cost of care growth cap in the commercial market as you do on the public sector market. And I think the path to it, that chart I showed you, that 92% of Americans rely on some form of public subsidy. So I think the path to a future runs through that part of the system that's financed with public dollars.
So would you be treating healthcare like a utility then? Because that seems like what you're talking about.
I think essentially that's what you are talking about for some basic level of care. So let's use the public school system as an example. So we publicly finance education because we recognize that it's important. It's a public good. Right, and so everyone pays for education. People who have kids in school, people who don't have kids in school, right? And all our kids get the same educational opportunity or benefit, which is 12 years in the public school system. You can argue whether that's good or bad, but it's the same. And when we run out of money in the public school system, we don't change eligibility. We don't say, well, we're not going to teach the 12th grade this year, or if your family makes more than $30,000, you can't go to school. Everyone stays covered. And what we focus on is the benefit. We basically, bigger class sizes or fewer electives, right? Now, parents that want to give their kids additional benefits can do that, but they do it with their after-tax dollars. It's not subsidized. And I think ultimately what this country needs and this state needs is a basic defined benefit, which is essentially treated like a utility in the sense that we're going to pay a certain amount for it based on a global budget, and that can be a negotiated budget, but it's got to be a fixed budget. And the key is that it grows at a sustainable growth rate, and then people can buy additional services above and beyond that with their after-tax dollars. Yes, sir.
Americans, the court system backs up patient access. As you know, I don't know from law students, 80% of the healthcare dollars spent on 20% of people. Half of your healthcare dollars spent in your last 6 months of life. We've had numerous court cases where people say, I want access to this drug. It's not in protocol. It hasn't been proven. Look at what happened in 1980 with total body irradiation for metastatic breast cancer and bone marrow transplants. People sued their insurance companies. One, we had to spend $10 million for something that proved not to work. So for the law students here, you guys are all, and gals, are all taught to fight for your client, but you're just asking the whole law system to then say, no, the public cap is more important, that you're going to have to say no to some people.
Well, here's the thing. You're right. And we just say no to people all the time. We just don't acknowledge it. So let me tell you, I'll tell you a story. I agree, and this is something we're going to have to come to terms with. I mean, if these are public dollars, at some point you have to ask, at what point does the right of an individual to have access to health care deny other individuals access to any health care? That's the fundamental question. We have to confront that. So in 1987, Oregon stopped funding Medicaid transplants. Stopped funding them. I don't think it was intentional, but it was buried in the larger budget, a very small program. We stopped paying for them. An explicit social rationing decision. Legislature goes home in June, and in September, a little 7-year-old boy named Kobe Howard shows up. He's on Medicaid. He has acute lymphoblastic anemia, and his pediatrician applies to the state for a bone marrow transplant, which he no longer covered. So he turns to private fundraising. So suddenly this is front page news in Oregon and across the country. He died in Emmanuel Hospital on December 3rd. He didn't have a match. Probably wouldn't have survived, but it was a terrible and very visible human tragedy, made more so because we could see it coming. The next year, a motion was made to the Legislative Emergency Board. In those days, we met every other year, and there's this 17-member body in between, to fund the transplants for 8 people who had applied. I was Senate President, Vera Katz was Speaker of the House, and we opposed the motion. And it wasn't because transplants didn't have merit, because they do, and it wasn't that we didn't have $200,000. The question was, if the state of Oregon is going to spend more money on health care, where should the next dollar go? And what's the policy that would spend money on 8 people? What do you tell the 9th or the 19th? And why should we spend money on transplants when 300,000 kids didn't have access to any coverage whatsoever? Was one more important than the other? So I remember going on the Today Show with Brian Gumbel. Turned out to be kind of a jerk. Jane Pauley's there with her kid in a crib off the side, and I'm with a guy named Craig Irwin, a great young man whose mother needed a liver transplant. So we're there, and Brian Gumbel first starts showing pictures of Kobe Howard and shows pictures of Craig's mother, and it gave him an opportunity to speak, and then it was my turn. And it was real clear to me from the beginning that he was defending his mother, whose picture was right there, and I was arguing on behalf of hundreds of thousands of nameless, faceless people. And his last question was, well, so what do you tell Craig's mom here, sorry? And all I remember of that is that I looked really good. I had no wrinkles. I had no gray in my hair. And I looked like a cold, icy son of a bitch, right? So the result of that was the Oregon Health Plan, which was essentially a priority list. It really had little to do with healthcare. It had to do with equity and accountability in the allocation of resources. And if you look at the law, so for those of you who aren't familiar with it, we prioritized health services from the most important to the least important based on social values and clinical effectiveness. That went to an independent actuary that determined the cost of each element. Then that was what the legislature got. And the legislature was prohibited from moving things up and down the list. They just had to make an appropriation. So the first list came out in 1991, and the first time we used it was in 1993. There's language in that law that says a physician, I'm surprised this hasn't been, one of you guys hasn't sniffed this one out. Should have term paper for you. It says a physician will not be held criminally or civilly liable for not providing a service that society has chosen not to fund. I think that's still in the law. But as it turned out, we had only one high-profile case, and it was a tragic case of a young woman, I think her name was Brandy Schroeder, who had cystic fibrosis, and she had applied for a heart, liver, lung transplant, which is an experimental procedure, and we didn't pay for it. Someone came in, Mark Hemstreet of, what are those inns? The Shiloh Inns, bought our transplant. It didn't work. But there was not a public outcry because we treated this transparent process. All I'm saying is that we ration every day. And the question is, do we as a society want to assume responsibility for our limits, or do we want to give health care to people who are cute enough to get on television or who can win a court case? And I don't know the answer to that, but I'm just saying that until we come to terms with this, the system's going to keep going up. And the cost in the system, I don't think, are these extraordinary cases. I think it is the drug companies that basically, on one hand, that don't have to negotiate prices with anybody. I think it is, there's a book you should read if you're going to go into health law, and it's called An American Sickness. It's by a woman named Don Quixote. It's by a woman named Elizabeth Rosenthal. She is an ER doc, was an award-winning reporter for the New York Times, and now is the head of Kaiser Health News. And it is, to me, it is as important an expose as up to Sinclair's The Jungle was in terms of exposing the exploitation of migrants at the turn of the last century. It's very powerful, and it shows you that there's more than enough money in the system to provide everybody with everything that's reasonably effective. This isn't a money problem, it's a resource allocation problem. And I believe that what we discovered with the CCOs is if you put a hard cap on the cost of care, people figure out how to make a margin. The CCOs are making money on a 3.4% growth cap, right? So I just think that, I don't know the answer to that, but I think it's a really interesting one for people who are in the law to puzzle over. Yeah. Yes, ma'am.
I'm a retired veterinarian. Owned and operated my own veterinary hospital in Salem for more than 30 years. I own my own building, I hire my staff, I buy my supplies. And there are a lot of parallels between veterinary medicine and human medicine. There is no way a pet owner would pay the price that the people have to pay for a bag of lactated ringers, an EKG, antibiotics, insulin. So the drug companies and the medical suppliers charge it because they can. They can. You know, animals don't live as long, animals get euthanized, but there isn't really any good health insurance. But veterinarians deliver many of the same services. And so what I'm telling you is if dog owners are willing to pay 20 cents for subluxin, why should it cost $1.50?
Exactly.
It still gets produced.
So we'll take another question here, then we'll go to here. Okay, yep, sir, way in the back.
Oh, thank you very much. First of all, Governor, thank you for your conversation with us about this. This is important. I'm Ed Junkins. I'm from the Osteopathic Medical School in Lebanon.
Yeah,
I too am an emergency physician, and I've got 9 medical students from our medical school who are here.
great.
And they are here. I'd like to think they're here because we talk about and teach people social determinants of health. They are all individually here because they care about taking care of their patients one by one, and they're looking at everything that you just said, and they see that inefficiency. I'm really super proud that they're here. My question is, I know that Senate Bill 770 is now set up in Oregon to create a universal task force on universal health in Oregon. And I just would like to hear a comment on what it would look like over the next 2 years for that task force to be effective in moving our state towards universal coverage.
Well, we're basically down to about 5 or 6% uninsured, right? I mean, so it's it's not a single payer, but it is we're almost there. So the real question to me is not universal coverage, but how do you manage the cost of universal coverage? How do you deal with the cost drivers within the healthcare system? Certainly, a single payer system is one way to do it. It's not the only way. To me, the single payer is less important than universal coverage. Single payer is one way to get to universal coverage. Here's another way. So let's supposing you were to expand Medicaid up to, let's say, 400% of the federal poverty level, to a point where when you get off, you actually can afford an individual policy. And that we adopt a CCO-like model for that, and over time use the cost savings to expand coverage, which is essentially what we did. Suppose over for Medicare, you created an incentive to move more original Medicare to Medicare Advantage and to move those from fee-for-service to some kind of a capitated system, and that you pool the purchasing power of both this expanded Medicaid and Medicare. So 59% of Americans have an income under 400% of the federal poverty level. So if you have a purchasing pool of, let's say, 200 million people, you repeal the provision in Medicare Part D that prohibits negotiation on drug prices, and you negotiate drug prices, hospital costs, physician costs, physical therapy, ambulatory surgery, and all these niche markets that have been developed to maximize revenue at the public expense. So it's a market approach, but it pools the purchasing power of the public sector. And if you think about that, that's not radical. Every large employer does exactly the same thing. Hospitals have consolidated to have more market power, so have insurance companies. And if these are public dollars, we ought to be getting the best value and the best price for our constituents, which are the taxpayers of the United States. So I do think in Oregon it's small enough where we could actually experiment with how you get to universal coverage. If the task force comes out with just a single payer system without dealing with the underlying healthcare cost structure, it's not going to work. And I don't know what they're going to come out with. I mean, it gets into this whole question of whether healthcare is a right or not. Oh, I'm sorry, right here.
I just think tagging onto this, it might be useful for anyone who doesn't understand how the waiver and the CCO model enable the money to be spent differently to help bring the cost down.
Well, so the CCO model basically, first of all, the secret sauce to me of the CCO is that it's a community-based organization. So it's a defined population, and you're sharing risk and responsibility for quality and outcomes in your own community, which is really, really important. Secondly, we developed a whole series of quality outcome metrics. They were called incentive metrics. So if you met these metrics, you got an incentive, which really works actually in changing care. And there are 15 different models. So it's a lovely laboratory. Eastern Oregon the Eastern Oregon CCO covers 12 counties and 48,000 people and 4 rural hospitals. And rural hospitals are struggling right now, and they're struggling because they don't do well under fee-for-service because they don't have any volume. And also a rural hospital is different than an urban hospital. It's a community center and a major community employer. So what they did is they formed an LLC, and the hospitals are equity owners, so they go up and down. I mean, it's a fascinating model. So my point is that once you constrain the rate of growth, and we're not talking about grabbing a whole bunch of money out of the system, we're talking about reducing the rate of growth to something at or below, preferably below the CPI, which then creates this delta of savings that you can reinvest.
Governor, we have had a question both on the wire, and also one of my students, Sam Clausen, is here, who might be able to address the situation. But we have apparently a constitutional amendment that's going to go to the voters, and what do you think that will be able to do, if anything? Will it be able to change perhaps some thinking along these lines?
So I do have a pretty strong view of that. I haven't read this one, so let me speak in general, because this may have some nuances that I'm not familiar with. But the notion that healthcare/medical care is a human right really troubles me, because we know that among those things that keep you healthy, only about 10% are medical care. So why shouldn't you have a right to housing? Why shouldn't you have a right to a good job? Why shouldn't you have a right to a stable family and a safe community? So, so I think it takes us down a rat hole. I would rather have a constitutional amendment that says in Oregon, everyone has a right to an equal opportunity to be healthy, which means, yes, they have to have access to some basic level of medical care, but they also have to have, we can't have the kind of disparities we have in employment, or in community investment. It basically expands the conversation. So I think it sounds good. It's probably a pretty good political soundbite, but it doesn't. But it assumes that medical care is synonymous with health, and it just isn't.
Thanks again. I thought that was a great talk, and I think that's a really important point to make for me. Like the conflation between health and health and human status, I think is a big point that is missed in the argument. But then kind of circling back to the idea of getting the most value for our money we spend, particularly taxpayer dollars. And you mentioned Medicare Advantage and maintaining the commercial insurance market. And I was just kind of wondering, I know it was reported last year that Medicare Advantage overcharged the Medicare program something like $30 billion just the last 3 years. And then, commercial insurers are operating with like a 15% overhead. So how do we talk about getting the most value for our money and being able to divert savings into public health measures like housing, jobs, food security, when there's people still taking a cut?
Yeah, again, I think it's important to make, at least in my mind, to make an important distinction between that growing part of the system that's financed with public dollars and that part that's financed with people's private after-tax dollars. I'm not saying people shouldn't be able to do whatever they want with their after-tax dollars, and there's a lot of profit there. But I think public dollars are different, and I think that with both Medicare Advantage and if you were going to extend some kind of growth cap on the commercial market, which would be the value of the tax exclusion, which is about $400 billion a year, I think you have to target administrative cost. This is the amount of money you can spend on administrative cost. Here's what's your capitation rate, and here are the outcomes you've got to produce, and you don't get any more money. the Providence Health Plan, for example, I'm talking not talking about their Medicare Advantage product, but what essentially it does is it's a good model. They'll get, let's say they have $800 a month. A certain amount of that is administrative cost, and I think you can make that pretty skinny. Then a certain amount of that's given to primary care docs. And if they can reduce unnecessary referrals to specialists and soft medical hospitalizations, they get 50% of the cost savings. So you begin to align the incentives, right? So there are models out there that are actually doing this. I think the political challenge is how do you get from here to there? And that's where I think that in Oregon, with 25% of the population on Medicaid and about almost 1 million people on Medicare, so that's about 2 million people plus 300,000 public employees, you can begin to get your arms around it. And I do think that I'm hopeful that the Universal Coverage Task Force, in conjunction with the task force on a total cost of care benchmark for the commercial market, can come up with a strategy to move us from here to there. I think it's really difficult to do this at the congressional level. Yes, sir.
When you go around the country, I would make a plea to empower the CCO medical director. So when I've dealt with national TRICARE for our veterans, they are at least a decade behind. So I have a hardworking veteran who's got a serious infection, and I need to give him IV antibiotics for 4 weeks, and TRICARE won't pay for that as an outpatient. He can go to work for half day, come read a Sports Illustrated, go home with his family. He has to be an inpatient.
Yeah.
And when you call TRICARE, there's no one to appeal to. Whereas when we had our IPA, Independent Physician Association, in this community, I would call medical director. She'd call me back in 15 minutes and say,
Yep.
it's better for the patient, it's cheaper, give me 15 minutes.
Yep.
So just please push that we can't have people on the East Coast
Right.
codifying things.
Right.
There's 330 million individual chemistry sets walking around.
Yep. Yep.
Guidelines are guidelines. Guidelines were not written in stone and given to Moses.
Well, so my approach to all this stuff for the last 35 years is you basically don't let your thinking be constrained by federal rules, regulations, guidelines. You say, this makes sense. The Oregon Health Plan was totally illegal. I remember drawing this up on the board, and we'll just make we'll get this priority list. And Gene Thorne, who was head of the Medicaid program, she says, John, this is illegal. I said, well, we'll just go get a bunch of waivers, which is an interesting story. 4 years later, we got the waivers. But I think that's where it's got to start, which is why I think what we're doing in Oregon is so incredibly important. The first question you ask is an incredibly important question, right? Washington State had a class action lawsuit, which you're probably familiar with, over treatment for Hep C. And what they were doing is they were treating people on Medicaid they weren't treating asymptomatic people. If you got symptoms from your Hep C, then they would treat it. The class action lawsuit mandated that you had to provide it for everyone. That was a $2 billion growth in their drug budget. And of course, what happened is that came out of schools or daycare, right? And so somehow, and I guess this is a question back to the legal community. How do you balance that? And healthcare is very similar. I was trained to healthcare is really personal. Injury, death occur to a person, one at a time, one life at a time. And so the whole medical profession is focused on one person, one life at a time. And that's how I practiced until I went to the legislature. And I was in the legislature as Senate President and practicing in the ER. And we balanced the budget in 1986 by dropping 4,300 people off the Medicaid program. And I thought it was really easy, and it bothered me. And in September, a guy came into my ER with a big stroke because we dropped his coverage in May, and he couldn't afford his blood pressure medication. And I caused that stroke as if I'd hit him in the head, right? And so that's what created this aha moment for me. So I don't know the answer to that, but somehow this society has got to figure out, with a $22 trillion national debt that we're leaving our kids, we've got to figure out how we're going to balance individual needs and rights with societal needs and rights. And they do it all over the world. They do it in Europe. They have this greater sense of social solidarity. But it is a real problem. It's a legal problem, and it's a medical problem. And we have to at least have a conversation about it. So thank you very much for bringing that up.
Governor, can we take one more?
Yeah.
One more question, please.
Thank you so much for coming. Very interesting talk. I just wanted to know what your thoughts are on a counter argument that I
Right.
it's going to end up costing them. They only know once they've already been seen.
Yep.
So what are your thoughts? Do you think if it was more transparent that if the costs were more transparent to consumers, that it would drive it naturally down in the marketplace so people could actually shop around and understand what they're paying for? Or do you think, like, I know that you I guess, argue for a mandated cap, but do you think if there was more transparency, it would naturally come down to a cap?
Yeah, so first I think we need transparency. It's just insane that particularly for elective procedures, let's say, you know, a gallbladder or a, you know, total hip, that you can't go to Providence or Legacy or Sacred Heart and get a good estimation of what it's going to cost. And it's like going to get your car serviced, and they say, well, we're not sure exactly what it'll cost you. We'll send you the bill later, right? It's crazy. And it has to do with this bizarre business model they've set up that has to do with difference between bill charges and rates and what they charge customers. And it's just friggin' insane. So I do think that transparency is really important, and we should push for that, right? At the same time, I don't think that it's going to have a significant reduction on the overall cost of care, because I don't think healthcare is just like another economic commodity. And I think the information asymmetry between consumers and the industry is just staggering. I mean, if you're a doctor today, I haven't practiced for a while, the amount of information that physicians have to accumulate just to stay current is mind-boggling. And for consumers, you know, to me, it is the maximizing revenue problem more than the transparency problem. Can I just tell you one really quick story, and then we'll go, because you mentioned something about end of life. You know, if we could figure out how to bend down the cost curve enough to begin to invest on the front end, which we know has huge benefits, you know, like let's take on childhood obesity instead of waiting and taking care of, you know, type 1 diabetics. The end of life's another important one, and this is one where I don't think you actually need a change in laws as much as you need a different conversation. So the story I'll tell you is the story of my own mother. She was 88, and my dad was 91, and she had a lot of muscle pain. And both my parents didn't want her to die in an acute care hospital. So I took her to the physician, and she had a real high sedimentation rate, which is a nonspecific indication of inflammation. She had some blood in her stool, so the possibility of an occult tumor was very high, and the workup would have been very invasive. And she said, I don't want it. And the doctor, very good internist, says, well, just check your blood work every couple of weeks and see how you do. And I said, why? And there's this kind of uncomfortable silence, and I said, you know, if you keep checking the blood work on an 88-year-old woman, you're going to find abnormalities because she's 88. And if you're not going to run them down, why check the blood work? And so I took her home, and her quality of life changed just like that. It was almost palpable. She and my dad had been living around their mortality and their disability and running up and down to the hospital when they shouldn't even have been driving. And suddenly they let go of what they couldn't control, which is the fact that they were elderly and that they were mortal, and they embraced the joys of their 63-year marriage. And so she lived for another 6 months at home. You know, I don't think she saw a physician. She had, you know, a nurse came in periodically. But she could have been, Medicare would have, if she died of congestive heart failure. And we were all there. She was in bed with my dad. We were sitting around there. They were playing the Messiah in the living room. And it was really sad. But it was beautiful. It's what she wanted. Now, Medicare would have paid to put her in the hospital for atrial fibrillation, renal failure, God knows what else, and the ambulance to take her there. But at the time, it wouldn't pay $18 an hour for a non-hospice caregiver to take her to the bathroom, to clean the house, and to shop for her. So my point is that I think that nobody really wants to end up in an acute care hospital, but that conversation, and you ought to be able to pay a provider, a nurse, social worker, physician, to have that conversation when someone's 40 and have that conversation with their family. And I guess for the physicians in the room, this ought to be a conversation that physicians step up and say we need to have in the community. Because I think that's a huge bunch of healthcare that actually is not what most people want. So I can't thank you enough for having me come down here. It's very stimulating.
Thank you so much, Governor.
Good luck to you.
Thank you so much. Governor Kitzhaber, thank you so very much. I also want to thank the Health Law Society for putting this on this evening, and we hope to do this more often. Thank you so very much.